So, uh, my name is Dr. Sym1 Suk from Chulalongkorn University, and another chairperson here is Professor Jacob George from Australia. So, Professor Jacob George, please introduce the speaker.
Thanks, Sym1, and welcome everyone to this second session on new paradigms in fatty liver disease. Each of the three speakers in this session will have 20 minutes. And our first speaker, who just gave the Chanavanti lecture before the tea break, Leon Adams, is going to be the first presenter. Leon, as you know, is an associate professor at the School of Medicine in Western Australia and has published extensively in the field of fatty liver disease. And his talk, the second talk of his, is entitled Diet and Vitamins for NAFLD, What's Known and What's New. Thanks, Leon.
Thanks, Jacob. So, although my previous talk was really about the advent of new drugs coming into play for fatty liver disease, the mainstay, as I mentioned, is really lifestyle change. And so that's going to be the focus of my talk today. We're going to be talking about, firstly, diets which may adversely impact on fatty liver disease, but also there may be some protective dietary factors that we should know about. And lastly, what's the experience in a clinical setting or clinical therapeutic setting of dietary management. And then I'm going to talk about largely just three vitamins which have got the most data and literature in fatty liver disease. So one of the problems when examining dietary composition and its influence on health is that various dietary items tend to be eaten together. So if you're going to be looking at the influence, for example, of donuts, then it's likely that you're also a person that eats a lot of pizza, for example. And so trying to tease apart the different contributions of these separate dietary components can be difficult. One way to account for this is to look at dietary patterns, and that is to look at groups of food which tend to be eaten together and to develop a score depending on whether you're likely to have a Western type diet or a more healthy type diet, which has been defined as these foods which tend to be eaten together. Now, we did this in a cohort of 14-year-olds, just under 1,000 in total, and followed them up over a 3-year period and then did ultrasounds to see whether they had fatty liver disease. And we found that 14-year-olds who scored heavily on eating a Western type diet were at much greater risk of developing fatty liver disease in the future compared to those who had a more healthy type diet. So, not surprising cause and effect type evidence for diet and fatty liver disease. There have been cross-sectional studies which have tried to look at the different micro and macronutrient profiles in people that have fatty liver disease or NASH, and then compared it to healthy controls. And it's clear that patients with NASH consume more saturated fat and cholesterol, more simple carbohydrates, and overall more calories. And this is not surprising. Correspondingly, they tend to eat less polyunsaturated fatty acids, less antioxidant vitamins, less dietary fibre and protein. And so this gives us a snapshot of perhaps the type of diets that we should be investigating to see whether they're therapeutic or not. One micronutrient which has got a lot of press in terms of its adverse effect on health in general is fructose. Now, fructose is common. It's found in table sugar or sucrose paired with glucose. And it's also a component of corn syrup, which is a popular sweetener in North America. Fructose occurs naturally. It's found in the highest levels in honey, naturally, but also in fruits and various sources. There's a lot of animal data to suggest its adverse impact on cardiometabolic health, and in particular reference to fatty liver disease. It increases lipogenesis within the liver, increases insulin resistance, but also has an inflammatory effect. In humans, it's been associated, fructose ingestion has been associated with increased toxin translocation from the gut, and we know that bacterial toxin is potentially injurious in fatty liver disease. And one cross-sectional study has suggested fructose is associated with hepatic fibrosis in fatty liver disease. And so there's, I guess, circumstantial evidence that fructose may be injurious or bad in fatty liver disease. However, if you look at the controlled feeding trials, when they take healthy individuals and actually prescribe them fructose up to 220 grams a day, which is about 7 cans of Coca-Cola, and look at its effect on hepatic lipid concentration, actually giving high-dose fructose that did not change hepatic lipid content in this series of controlled feeding trials. Now, note that these trials were isocaloric, so that is that their total calorie intake did not change due to the trial, and so their intake of fructose was not additive to their normal diet. However, when you do increase the caloric intake in your normal diet by adding fructose, so-called hypercaloric trials, then the hepatic lipid content did go up. So it's not clear whether fructose by itself has an adverse effect on hepatic steatosis from these short-term controlled feeding trials, or whether it's just an effect of eating more calories. But it may be that there's confounding effects. So the presence of concomitant dietary fat has been shown to increase hepatic lipid if you take it with fructose. And similarly, the effect of dietary fructose may be only a factor in patients who are obese. And this data again comes from the RAIN cohort, where we found that dietary ingestion of fructose only increased the risk of fatty liver disease if you were obese to start off with. And lastly, there may be genetic factors which determine the influence of fructose. And this study from the New England made a genetic risk score, and depending on what quartile were of genetic risk, defined the increase in body mass index that you had per gram of fructose ingestion. And so the fructose is probably not the be-all and end-all of fatty liver disease, and probably depends on these other factors. Coffee, on the other hand, may be protective. There is some epidemiological evidence to suggest that coffee ingestion is associated with a lower risk of future chronic liver disease and hepatocellular carcinoma. Cross-sectional studies from the NASH CRN have shown that coffee ingestion is associated with a lower risk of hepatic fibrosis. And again, in epidemiological studies have suggested in the general population that coffee ingestion is associated with a lower risk of serum ALT. Adding to, I guess, some evidence of proof of cause, there is a dose-response effect, and it appears that coffee, rather than the element of caffeine, is important. And this may be related to polyphenols within the coffee, and also it's the caffeinated version rather than the decaffeinated, which has the most evidence. So this really all is epidemiological and some cross-sectional data, so certainly not that high level in terms of cause and effect. Interestingly, however, coffee may be protective of fructose-induced insulin resistance. And this interesting study looked at 10 healthy volunteers where they were fed a high fructose diet, and then 3 of the groups were fed coffee for a week period before the fructose overfeeding. And the coffee was both caffeinated and decaffeinated, and high and low in chlorogenic acid, which is a polyphenol thought to be one of the active agents. And at the end of this study, they looked at the intrahepatic lipid content. And note there's actually no change in hepatic steatosis with coffee after fructose ingestion, but coffee did improve lipid oxidation, reduce glucose oxidation, and improved hepatic insulin sensitivity when they did clamp studies, suggesting some therapeutic effect. Now note that this is only a very small trial, and this trial was actually in normal volunteers that didn't have fatty liver disease. Their hepatic lipid content was only 1.5% rather than more than 5%. So it would be interesting to see whether a similar study can be done in fatty liver disease. So it's too early yet to say coffee is the therapeutic panacea for fatty liver disease, but certainly there is some suggestive evidence. There's also a number of dietary supplements which have mainly been examined in animal models, which have been purported to have metabolic and therapeutic effects in fatty liver disease. However, there is really not much in the way of human data, and again, I don't think we can be recommending any of these agents as therapies for our NASH patients. So moving on to diet, which is, again, is the mainstay of treatment. So the questions I want to ask are how much weight do we need to lose with diet, what kind of diet should we be prescribing, and what's the sustainability of these dietary interventions. So I've shown one of these studies before in the last lecture, but this demonstrates the efficacy of losing weight on, firstly, hepatic triglyceride measured by magnetic resonance spectroscopy in this study from Vincent Wong, and also this study from Cuba, which was 12 months with paired liver biopsies. And in both groups, they had very similar numbers. You can see that if you lost more than 10% of your body weight, almost all patients either lost fat from their liver or resolved their NASH. So again, dietary intervention through weight loss is very effective if it can be done. Unfortunately, the majority of patients in both of these studies did not achieve significant weight loss. How about the type of diet that we should be prescribing? And so if we talk about the high-fat, low-carb or the low-fat, high-carb diets, it depends on whether you're increasing your whether you're maintaining your caloric intake or whether you're reducing your caloric intake. So if you have an isocaloric
ช่วยดูไมโครโฟนนะครับ
So if you maintain the amount of calories that you take in and aren't attempting to lose weight, then it's clear that a low fat over a short-term period reduces the amount of hepatic fat, although the changes are relatively modest, generally less than 1%. However, if you are actually losing weight, it doesn't matter whether you have a low-fat or a high-fat diet because they have equivalent changes in hepatic steatosis over an 11 to 24-week period. This is demonstrated in these two randomised controlled trials. However, not all fats are equal, and saturated fats are obviously are worse than polyunsaturated fats. And again, looking at in these series of studies, it didn't matter whether you were maintaining your body weight or increasing your body weight. Saturated fat had adverse effects on hepatic lipid content, whereas polyunsaturated fatty acids had a protective effect. So how about monounsaturated fatty acids? So MUFAs are typically found in olive oil and are acknowledged to be high in the Mediterranean diet. And this small crossover trial from Melbourne demonstrated that if you were not, in the absence of weight loss, that a Mediterranean diet had significant reduction in your intrahepatic lipid content, as well as an improvement in your insulin sensitivity, suggesting perhaps an advantage of the Mediterranean diet over the standard low-fat diet. We also know that the Mediterranean diet in patients without fatty liver disease but at risk of cardiovascular disease reduces cardiovascular events as primary prevention. And this came from this New England trial where those on the Mediterranean diet supplemented with nuts or extra virgin olive oil had a lower risk of this composite cardiovascular endpoint. And so given that NAFL patients' cause of death is most commonly cardiovascular, this may be a sensible diet to recommend. So as mentioned, dietary sustainability is poor. Are there things that we can do to try to maximise the impact of dietary treatment? And this is one study which looked at 900 patients and plotted their probability of losing more than 5% of weight according to the number of clinic visits that they attended and also their baseline body mass index. And you can see that if they had 2 clinic visits over the span of a 17-month period, that they didn't lose weight. But with increasing number of clinics, up to 5 or more clinic visits, the weight loss was higher. So the more engagement that we have with our patients, the more support that we give them in terms of their weight loss, we're more likely to actually achieve effective dietary management. Not only clinic visits, but the intensity of intervention has been shown to not only improve weight loss, but it's also been shown to improve histological endpoints in fatty liver disease. And this is a randomised control trial, just demonstrating that if you see your patients once every 3 months and give them a little bit of education, as opposed to a more intensive weekly to fortnightly intervention, that you'll actually have a reduction in your NAFL activity score over that year. So suggesting that although this is costly, that if we are going to see these effects, we need to put time and resources into it. So the second part of my talk is really concentrating on the vitamins and vitamin D. I'm not going to belabor this pathway of vitamin D metabolism, but just to highlight the point that there are 2 sources of vitamin D, from the sun as well as from dietary sources, and this will be important in a couple of slides' time. So vitamin D deficiency has had a lot of press in cross-sectional and cohort studies to be associated with adverse outcomes, and really the hard outcomes such as overall mortality as well as cardiometabolic outcomes, which are important in NASH. However, when they've done interventional studies with vitamin D supplementation, the effect of vitamin D supplementation has really been disappointing, suggesting a disconnect between what we see in the epidemiological studies and the actual clinical intervention. And it's similar in fatty liver disease. So this is an association of vitamin D deficiency with the probability of having fatty liver disease. So you can see that if you're insufficient or deficient in vitamin D, you're much more likely to have fatty liver disease. And this is independent on multivariate analysis. Vitamin D deficiency has also been associated not only with fatty liver disease, but also the severity of scarring or fibrosis in fatty liver disease. And these 2 trials demonstrate a reduction in vitamin D levels in patients that have advanced hepatic fibrosis. There is not much in the way of clinical intervention trials looking at vitamin D, but what there are not encouraging. And so in this randomised control trial of 53 patients, there was no effect on serum ALT. And this single-arm trial of patients that were deficient or insufficient found that after 24 weeks of high-dose supplementation, there's no change in your NAFL activity score on paired biopsies. So mirroring the experience in other metabolic conditions, vitamin D has not yet been shown to be efficacious in NASH. And perhaps this may be due to one of the confounding effects or one of the other effects, forces changing vitamin D levels, namely sunlight. And so these 2 interesting animal studies show that if you induce fatty liver disease or NASH through a high-fat diet or a CDA diet, and then give the animals UV light, that you'll get an improvement in their liver histology with the UV light. So maybe it's the sunlight rather than the vitamin D per se, which is therapeutic. Vitamin E, there's actually 8 different isoforms of vitamin E, and the most abundantly studied is alpha tocopherol, and this was given in the Pivens trial, which I've shown this slide before, just demonstrating that it did result in improvement in NASH. This is the equivalent study done in the paediatric age group, where vitamin E also was demonstrated to significantly improve patients with NASH. But again, note that the percent of patients that improved was relatively minor. There is concerns about toxicity, so this is some studies which have raised concerns about long-term vitamin E use on mortality, heart failure and hemorrhagic stroke. I do stress that there are other meta-analyses and large trials which don't show any effect on vitamin E on these outcomes, and so I think this concern about vitamin E toxicity is still somewhat unresolved. And lastly, talking about choline, which is one of the B vitamins. The majority of choline is derived from dietary sources, such as fish and nuts and eggs. And importantly, your gut bacteria metabolize choline and so play a part in determining the bioavailability of choline. You do synthesize a small component of choline in the form of phosphatidylcholine, and this is done by the PMT pathway, which is influenced by estrogen and genetic polymorphisms. The importance of choline in fatty liver disease is that it's required for your triglyceride export, and notably choline deficiency has been used as animal models for fatty liver disease. In terms of the association of the dietary choline and risk of liver injury, this study from the NASH CRN in the US showed that, looked at 4 groups of individuals, children, male, female, and females pre and post-menopausal, and demonstrated that the risk of fibrosis or advanced fibrosis was greatest in females with choline deficiency and greatest in those post-menopausal, which are obviously those with least estrogen. Interestingly, these observations have also been examined in this trial where they took 15 females and they gave them induced a choline deficiency by giving them a choline deficient diet. And then they looked at whether their liver fat increased. And their liver fat increased depending on what kind of gut microbiome they had and what kind of genotype they had of the PMT gene. And so this illustrates quite a nice interaction between the host genes, the host gut microbiome, and the diet to give rise to fatty liver disease. And so these sort of complex interactions are likely to be playing on a much larger scale than we appreciate. And so just in conclusion, we know that high fat diets, particularly those in saturated fat, increase hepatic fat and should obviously be avoided, whereas the unsaturated fats are preferable, and particularly the MUFA diet with Mediterranean diet. There is evidence that fructose may exacerbate fatty liver disease, but it may do so in the presence of other factors such as total fat intake, obesity, or those who are genetically predisposed. Coffee may be protective of liver injury, but further data is required. And I guess the take-home message is that weight loss is much more important than the macronutrient composition that you're taking, and we should be aiming for 10% or more of weight loss, as this has the most beneficial effect on histology. And lastly, therapeutic weight loss requires intense intervention. This is not just something you say at over a 2-minute consultation. This requires a plan, resources, and recurrent review. Vitamins deficiency is associated with fatty liver disease of vitamin D, but supplementation has not been shown to be beneficial. Vitamin E has been shown to be beneficial, but only in a minority of low-risk patients. And choline deficiency has been associated with hepatic steatosis, but mainly in certain subgroups. Thank you for your time.
Thank you. So I will introduce the next speaker, Associated Professor Poonchai Jarat-Chalerm Vithaya. Currently, his work at Sirirat Hospital, Mahidol University. He graduated from Mayo Clinic, Rochester, Minnesota, and Currently, he published several articles related to fatty liver disease. Professor Punchai, please.
Thank you very much, Dr. Symbat, for kindly introduction. First of all, I would like to thank the APLD Scientific Committee for inviting me to give a talk in this topic with another two experts in this field. This is an outline of my talk. I will start with the basic of the gut microbiome and its relationship to health and the disease, and followed by the pathogenic association of the gut microbiota to the NAFLD. And lastly, I will touch on the potential therapeutic intervention modulating gut microbiota in NAFLD. It has been known that the microbiota have a complex role in the human health and the disease. With the advancing knowledge, the microbial community of the GI tract, the gut microbiota and their collective genome that we call the gut microbiome, and intervention targeting the gut microbiota are increasingly recognized as a potential therapeutic route for many chronic diseases, including liver disease. That's why this is the exponential growth of the human research in the gut microbiota over the last decade. Currently, culture-independent method has been developed to study the microbial community. This makes the advance in the knowledge of this human microbiota. Profiling this community, the fecal microbiota, by using the 16 liposomal RNA survey and by the direct sequencing of the gene material, have shown that the human gut microbiota is a complex community of the 100 trillion bacterial cells, and the genome of the microbiota contain 150 times more than the human genome. As you can see in this slide, the community is dominated by the bacteria. That's with the more than 90% of the species is belonging to Firmicutes and Bacteroidetes. Each person had a distinct and highly valuable in microbiota, but a conserve a set of the gut colonizer and the core microbiome was shared among individuals. This may be required for the correct functioning of the gut function. The adult light intestinal microbiota is regarded as the relative stable throughout the adulthood until aging. However, the several studies have shown that the composition of the human gut ecosystem could be influenced by the multiple and diverse factors, some physiologic, including age, origin, environment, and other linked to the external factors such as the dietary habit, antibiotic, and probiotic. Several evidence suggests that the gut microbiota play a central role in the numberless human physiologic function. One example is that act as the physical and the biochemical barrier against the pathogen in the GI tract. Synergistic and the commensal microbiota in the mucosal layer acts as the competitor against the inverse by occurring binding site restrict the pathogen bacteria from the nutrient, and the producing and the stimulation the synthesis of the antimicrobial agent. Recent data indicate that the high microbial diversity is associated with the health phenotype, whereas the loss of the diversity seems to be correlated with the disease. The list of the disease linked with the gut microbiota is increasing, and the ranging from the intestinal disease like inflammatory bowel disease, irritable bowel syndrome, celiac disease, and the colorectal cancer, and to extra-intestinal disorder like a metabolic disease including obesity, diabetes, and the NAFLD. The evident link between the gut microbiota and the NAFLD most came from the experimental study investigating in the animal study. Germ-free mice are those born and fed without exposure to any live microbe. They provide a powerful tool for understanding of the effect of the gut microbiota on the pathogenesis of the NAFLD. In my study conducted by the Leroy and colleagues, they showed that the gut microbiota from mice who fed with the high-fat diet developing liver steatosis, hyperglycemia, and systemic inflammation. were transplanted into the germ-free mice, and these mice developed the high-fat hepatic steatosis and increase in the expression of the gene involved in the de novo lipogenesis. This result suggests that the gut microbiota influence the whole body glucose homeostasis and liver lipid metabolism, indicating that the gut microbiota constitute an environmental factor driving the progression of the NAFLD. In the human, the first evidence of the gut dysbiosis might be involved in the NAFLD pathogenesis was provided by a few cross-sectional studies that evaluate the association between the gut microbiota and the liver phenotype of the NAFLD patient. Using the quantitative polymerase chain reaction for selected bacteria in the small cohort of the 50 patients, Musaki and colleagues showed the NASH patient has decreased in the fecal bacteroidetes and increased in the Clostridium coccoides. The negative association between the NASH and the bacteroides persists after adjust for the BMI and the daily fat intake. Another exploratory study conducted by Su and colleagues, they screened the whole gut genome by using the 16 RNA payload sequencing in the cohorts of the 63 children that include the 16 healthy control, 25 obese subjects without known of the liver disease, and 22 patients with NASH. They found the fecal species lead NASH are diminished in the obese subject, as you can see in the figure A, and in NASH patient when compared to the control. At the phylum level, the obese patient and NASH patient have the similar increase in the bacteroides and decrease in the firmicutes compared to the control group. The Musaki and the Su study, as you can see in this slide, the result may seem quite conflicting. The first one is show the decrease in bacteroides, and the second one that show the increase in the bacteroides. However, the different population was studied, include the adult versus children and control, biopsy-proven steatosis and obese patient without histology, using the different approach. Also, both work were limited with a small sample size. Therefore, the further study, including the large and well-characterized cohorts, are required to better identify the association between the gut microbiota and the various phenotypes observed in the NAFLD patient. Based on the several lines of evidence in animal study and the human study, gut microbiota may stimulate the hepatic fat deposition and promote NASH through the several mechanisms. First, it may promote the obesity by improving the energy yield from the food. Secondly, it regulates the gut permeability, locate inflammation, and the immune balance. Thirdly, gut microbiota may modulate the diet choline metabolism, as you can heard from the previous lecture by the Professor Adam. And then it's increased endogenous alcohol production by the bacteria. And finally, it may regulate the bile acid metabolism. Let me start with the role of the microbiome in the energy harvesting and its storage in the adipose tissue. Several studies show that gut microbiota help in extracting calories from the indigestible polysaccharide in the diet, converting this polysaccharide to the monosaccharide and the short-chain fatty acid in the colon, which after absorption cause the triglyceride synthesis in the liver. This concept have been supported by the animal study showing that the increased energy harvest and the increase in the body fat after the transplant of the obese type microbiota in germ-free mice. Stool examination in this animal show more end product of the fermentation, and the few calories suggest that increasing in the energy extraction and stored by the obese type microbiota. This result identified the gut microbiota as the additional contributing factor to the pathophysiology of the obese and the fatty liver disease. Choline is a phospholipid component of the cell membranes and they play important role in the fat metabolism in the liver. It helps in the VLDL assembly and the lipid transport from the liver. Therefore, the deficiency of the choline can lead to accumulation of the fat in the liver, as seen in the choline deficiency animal model of the hepatic steatosis. In the recent study, 15 female subjects were placed on the well-controlled diet in which choline level are manipulated. Pilosequencing of the bacterial gene were used to characterize microbiota in the stool sample. Hepatic steatosis was measured by MR imaging at the beginning and at the end of the baseline after 21st and 42 days of the low choline diet. The investigation found that the composition of the gut microbiota changed with the choline level of the diet, which each individual maintained the distinct microbiome. Furthermore, gut microbiota could be contribute to the liver injury in the patient with the NAFLD by producing the endogenous alcohol. As you well know that the alcohol metabolism produces acetate and acetaldehyde, leading to the fatty acid synthesis and the hepatic oxidative stress respectively. Recently, the relationship between the gut microbiota and the endogenous alcohol was studied by RNA pilosequencing and the peripheral blood ethanol concentration in the NASH, obese, and the healthy children. Healthy subjects and the obese children had a different microbiome with abundance of the alcohol-producing bacteria, mainly Escherichia. Also, the NASH patients have the higher blood ethanol than the healthy and the obese non-NASH subject. This finding suggests that the link between the gut microbiota, endogenous alcohol, and the NASH. Bile acids are the regulator of the hepatic lipid and glucose metabolism and have the strong bactericidal action because of the effect of the bile acids on the bacterial cell membrane phospholipid. However, the gut microbiota can also affect the bile acid metabolism through the fascinoid X receptor or FXR stimulation, and its downstream signal play the important role in the control of the hepatic lipogenesis and the export VLDL from the liver. Here, a Mulin's model of the high-fat diet induced non-alcoholic fatty liver disease was used, and the effect of the alteration of the gut microbiota on the NAFLD were determined. Compared with the control mice, animals with the intestine-specific FSR disruption had reduced in the hepatic triglyceride accumulation in response to the high-fat diet, as you can see in this figure. Administration of the selenamide to antibiotic-treated mice fed with the high-fat diet can reverse the hepatic steatosis. This data suggests that the inhibition of the intestinal FXR is the potential therapeutic target for the NAFLD treatment. This is a finding have the clinical relevance because the obeticholic acid or FSR receptor ligand has been shown to improve the feature of the NASH histology among individuals with the biopsy-proven NASH in the phase 2 clinical trial, as you can hear from previous lecture. Bacterial translocation to the intestinal wall leakage and small intestinal bacterial overgrowth, or SIBO, has been believed by some authors to contribute to the progression of the NAFLD. The study conducted in mice indicate that the both factor may involve in the pathogenesis of the NASH. In a study published in Hepatology, 35 biopsy-proven NASH compared with the patient with untreated celiac disease and healthy subject for the presence of the SIBO and the gut permeability. The results show that the patient with the NAFLD had a significant increase in the gut permeability and higher prevalence of the SIBO, which correlate with the severity of the steatosis, but not with the presence with NASH. Therefore, the SIBO, by altering the intestinal integrity, may play an important role in the hepatic fat deposition. By altering the gut permeability, the gut microbiota are also responsible for the causing the endogenous endotoxemia and the systemic inflammation, secondary to the downstream signal following the toll-like receptor stimulation. Continuous the presence of the endotoxin in this patient might be responsible for inducing activation of the innate immune system in the chronic subclinical inflammation in this patient. By studying several knockout mice, the researcher discovered that more severe diet-induced NASH resulting from the influx of the intestinally derived toll-like receptor agonist into the portal system, which in turn to activate the TNF-alpha in the liver. This finding had the clinical relevance because the human study have demonstrated that the NASH patient had a higher endotoxemia and a higher level of TNF-alpha level than the patient with the simple steatosis. Although still dominated by the data from the animal study, early clinical data suggests that the manipulation of the microbiota by the diet, prebiotic, probiotic or antibiotic, or even fecal transplantation might modify the gut microbiota in the beneficial way that may lead to improvement of the NAFLD. The potential benefits of the probiotic have been confirmed in the several experimental studies, but very few human studies right now. In the animal study, VLS number 3 treatment have shown that it can effectively attenuate the fibrosis without the change in the steatohepatitis in the diet-induced NASH mouse model. In the recent human study by Dr. Wong, they serve as a proof of concept for the role of the probiotic in the NAFLD treatment. The patient with the biopsy-proven with NASH were randomized to receive either the probiotic or usual care for the 6 months. The probiotic formula contains 4 lactobacillus species and bifidobacterium bifidum. The probiotic treatment resulted in the significant reduction in the intrahepatic triglyceride content as measured by the potent MR spectroscopy, and the significant improvement in the AST level when compared to the control group. A recent meta-analysis that includes for the randomized control trial involving 134 NAFLD patients showed that the probiotic therapy can reduce aminotransferase level, total cholesterol, and improve insulin resistance in these patients. However, it is important to note that the currently published clinical trials are limited by the small sample size, the lack of the standardization of the probiotic formula used, the variation in dosing, and the lack of the histologic endpoint. How about the prebiotic? Prebiotic is a non-digestible oligosaccharide that acts as the fertilizer of the colonic microbiota and increase in the growth of the commensal organism including bifidobacterium and lactobacillus species, has been shown to be beneficial in the reducing adipose tissue in the animal study. In a pilot study, 7 patients with NASH received either the 16 grams per day for oligofructose or the placebo for 8 weeks. The results show that compared to the placebo, the prebiotic group had a significant reduction in the liver enzyme after 8 weeks and the insulin level after 4 weeks. Although the study of the probiotic and prebiotic are limited by the small sample size and the short-term follow-up, it however supports the role of the microbiome modifying change as the potential therapeutic option for the patient with the NAFLD. Ladies and gentlemen, this is my conclusion. First, based on this evidence that show that the substantial observation and experimental evidence has shown the association between the intestinal disc biopsy and the NAFLD. Further investigation are needed to evaluate the etiologic role of the gut microbiota in the development and the progression of the NAFLD. Application of the high technology along with the integrated analysis of the microbiome host data, a longitudinal follow-up, will help the clarify association between the dysbiosis and NAFLD. And lastly, better understanding of the potential mechanism underlying the NAFLD will ultimately allow the development of the novel targets intervention to halt the disease progression. Thank you very much for your attention.
Thank you very much, Dr. Punchai, for an excellent overview of a very complex subject and also explaining to us the difficulty of translating this sort of information to clinical utility for patients with fatty liver disease. In the interest of time, we might just move to the final speaker in this session. Again, Professor Vincent Wong does not need any introduction. He's from the Chinese University of Hong Kong, has published extensively in fatty liver disease, particularly with regard to epidemiological studies on incidence of fatty liver and also looking at MRI-based assessment of liver and pancreatic fat. So Vincent's going to conclude this session talking about liver cancer in non-cirrhotic NASH. Who gets it and can we prevent it? Thank you, Vincent.
Thank you, Professor George, for your kind introduction. So, Sawadika, good morning, ladies and gentlemen. So, once again, I would like to thank the organizers for the invitation and congratulate them for the successful meeting. Now, this is the first time I give this talk. This is indeed a very interesting and provocative topic. Now, over the years, we know that metabolic diseases have a great impact on the incidence of HCC. So, either in the general population or in selected population in patients with viral hepatitis, for example, we know that obesity and diabetes would increase the risk of HCC by 2 to 4-fold. Now, there are many reasons for that, but one of the possibilities is that this is mediated through the development of NAFLD and NASH. So again, if you look across different studies, so there will be different incidences of HCC depending on which population group you are looking at. Of course, if you look at NAFLD patients as a whole, the overall incidence is quite low, less than 1% over a long period of time. However, if you look at specifically high-risk group, those with advanced fibrosis or cirrhosis, then up to 1 to 2% per year would develop HCC. Now, if we look at the problem from another angle, how about if we look at the etiologies of HCC in different countries? So latest publication by Sabaya Yunosi tells us that NAFLD has already become the third leading cause of HCC in the United States after looking at the SEER registry. And importantly, it shows a great increase over time. So just over the period of 2004 to 2009, you see a 14.1% increase or a 9% annual increase of a NAFLD-related HCC, which is indeed an alarming figure. Now, if we know that NAFLD can cause HCC, of course, we need to know how to detect it and how to prevent patients from dying from HCC. Now, if we look across different regional guidelines, they all recommend screening if a patient has cirrhosis, regardless of the underlying etiology. So the ASLD and EASL would recommend using ultrasound only, whereas the Asia-Pacific Association also recommends the use of alpha-fetoprotein, which is commonly practiced in this part of the world. Now comes the provocative area. A Japanese group earlier in 2011 published a case series telling us that up to 50% of their patients with NAFLD-related HCC actually did not have cirrhosis, and some of them actually had mild fibrosis or no fibrosis at all. This is more prominent in male patients as compared with female patients. Now, you may think Japanese are always weird. They may come up with strange ideas. So this may not apply in your country or other countries. But indeed, when the Western world look into the matter again, they find a similar phenomenon. So this is latest data from the United States, again looking at a large number of patients. And they found that among NAFLD patients with HCC, around 30% again did not have liver cirrhosis. This is much higher, this proportion is much higher when compared with other etiologies like chronic hepatitis C, hepatitis B, and alcoholic liver disease. But it is comparable in patients with idiopathic HCC, and some of which we believe would be related to NAFLD as well. Now, if we see so many patients with non-cirrhotic HCC because of NAFLD, you may ask, why would that be the case? I can think of three possible explanations. These three explanations are by no means exclusive, and I think all of them are true to a certain extent. The first possible explanation is that this is basically selection bias. This is because some of the patients with NAFLD-associated cirrhosis will be classified as having cryptogenic cirrhosis because when a patient progresses to the stage of end-stage liver disease, the fat in the liver may be gone, and therefore you may say that those patients are not due to NASH. And if you classify some cirrhotic patients as not due to fatty liver, of course, more patients with NAFLD-related HCC would be considered to be non-cirrhotic. But there are other possible explanations as well. Now, compared with other liver disease such as viral hepatitis, I must say that fewer patients with NAFLD would have cirrhosis. And therefore, if you take that proportion into consideration, then more patients with non-cirrhotic NAFLD may harbor HCC. And finally, some of the molecular pathways of NASH may be conducive to HCC development. Now, the detailed discussion of the molecular pathways of HCC and NASH would be beyond the scope of this talk. But suffice to say, if you carefully examine the molecules involved in the pathogenesis of both conditions, you see many overlaps. So, for example, the pro-inflammatory pathways would be important in the development of NASH. For example, the PPAR and also the NF-kappa B would be central in the development of NASH. But you also see those molecules in HCC pathways as well. And just as another example, in this issue of the Journal of Hepatology, we also see that fatty acid synthase, which is important in the development of fat accumulation in liver cells, would also be pivotal in the development of HCC as well. But no matter which explanation you believe more, this creates the iceberg paradox. So we know that some of the NAFLD patients would have cirrhosis. They definitely would have a high risk of developing HCC. But overall, if you look at the entire population of NAFLD, this only comprises a small proportion of patients. The bigger proportion of patients would be non-cirrhotic. The absolute risk of HCC is small. But since there are so many patients harboring NAFLD without cirrhosis, so if you add them together, you see a significant proportion of HCC patients who are non-cirrhotic. So what would be the clinical implication? The clinical implication, first I can think of, would be the effect on HCC surveillance policy. Now, if you want to detect HCC due to NAFLD, you can have two possible strategies. The first strategy would be to follow regional guidelines and only provide surveillance for patients with NASH-related cirrhosis. The implication is that you would only focus on a small proportion of patients. However, you have to prepare to miss around 1/3 of HCC due to NASH. So this is not desirable. Strategy 2 would be you screen for HCC for all NAFLD patients. So by doing so, you are more likely to capture more HCC patients. But the question to you is whether you are prepared to screen 20 to 40% of your entire population, which is clearly not feasible. So we are stuck. Do we have a third strategy? I think there is. So first of all, we need better marker to predict who among the NAFLD patients would develop HCC. So beyond cirrhosis, we have to find additional risk factors. We also need good cancer biomarkers to tell us who are likely to develop HCC, and also we may even apply those biomarkers for screening. And finally, we have heard a lot of treatment as prevention in chronic hepatitis C, so I would also advocate that the same may probably be true for fatty liver disease as well. Now, do we have predictors of HCC beyond liver fibrosis? So this is a publication by late Paul Angelo telling us that actually the histological features of NASH, including the presence of portal inflammation and ballooning, would also increase the risk of HCC. However, we also learned from the same cohort that if you adjust that with the fibrosis staging, you do not see that NASH can predict HCC. So basically, the effect of NASH on future development of HCC can be largely explained by the fibrosis staging already. So this is not an attractive predictor. How about clinical predictors? So if we look across this Japanese study, you can see that a number of factors would be associated with HCC development over time. So in this large cohort of NAFLD patients, only a small proportion would finally develop HCC over a course of up to 12 years. Among the different risk factors, older age, higher AST level, low platelet level, which probably also reflects cirrhosis, and also the presence of diabetes would be independently associated with future development of HCC. So in particular, you can see that among patients who did not have diabetes at baseline, the risk of developing HCC is close to 0%. In this study, they also show that apart from using liver biopsy to assess liver fibrosis, you can also use some non-invasive tests, such as the EPRI score. Depending on the AST level and also the platelet level, you can also predict HCC. So again, if a patient has low EPRI score, the risk of developing HCC is close to 0%. The same findings have been replicated in Western studies. So in another study conducted in Europe, you can again see that diabetes is basically one of the important risk factors of HCC in NAFLD patients. Other risk factors in this study would include the PNPLA3 gene polymorphism, again, older age, male gender, and also BMI and the presence of cirrhosis. Now, we know a few clinical factors associated with HCC development in fatty liver disease. So clearly, older age, cirrhosis, and diabetes repeatedly come up. So the next thing we may need to do is, like in the field of chronic hepatitis B, to develop some HCC prediction score to tell us who among the patients we see in the clinic would develop HCC in the future. But since the incidence of HCC in NAFLD patients is much lower compared with patients with viral hepatitis, we would need a large sample size to accomplish that, and this would call for international collaboration. But this is something important we have to do because it holds promise to change clinical practice. The next thing we consider, apart from clinical predictors, would be, of course, biomarkers of HCC. Unfortunately, for the common tumor biomarkers we use to screen HCC in our clinic, including alpha-fetoprotein, or in some countries, including Japan, we may use a DCP or PIVCA. You can see that they are not good markers of HCC. So take alpha-fetoprotein, for example. Even among patients with HCC, the median value was only 7 nanogram per ml. So this indicates that more than half of your patients with HCC would not have high AFP level even at the time of HCC development, and therefore the tumor marker is close to useless. So new development in HCC biomarkers is another area we have to consider. Now finally, I would say some words about treatment as prevention. So we have heard from Leon Adams that lifestyle modification and some emerging pharmacological therapy will be important in our management of NASH. And also, if the patient is also morbidly obese, then performing bariatric surgery would also be very effective in improving the liver histology, including fibrosis and necroinflammation. But do they improve HCC risk? So suffice to say, if you lose a lot of body weight, you can reverse the histological or radiological changes of NAFLD and NASH. So if you lose more than 10% of the body weight, basically everybody would have improvement in NAFLD and NASH. But what I would like to highlight is that a lesser degree of weight reduction is not useless. So you can see from our study that even for patients losing weight by 3 to 10%, you also see substantial improvement as well. And lately, a basic research study has also told us that the weight reduction or exercise can also prevent HCC development in animals. So in this interesting study, they basically made the mice to run on treadmills, and you can see that by doing so, you can reduce the tumor size and also the number of HCC, even in a well-established HCC model. And I believe this would also be true in humans as well. By reducing body size, by doing exercise, by having a healthy diet, we can prevent HCC. How about pharmacological therapy? Now the pharmacological targets are still at its infancy. We are still debating whether the histological changes or ALT normalization would really predict future heart clinical outcomes such as HCC. So it will take many, many years before we know whether the new drugs can save lives. But what about the agents in the clinic right now? So if we look at different observational studies, it appears that among diabetic patients, at least the use of some of the agents are associated with a lower risk of HCC development. So in this particular example, for example, the use of metformin and thiazolidinedione, so both insulin sensitizers are associated with up to 25 to 30% risk reduction in HCC over time. On the other hand, the use of insulin is often associated with a higher risk of HCC or other kinds of cancer in different observational studies. But I have to highlight that the observational data we have to interpret with caution because the indication bias has not been completely adjusted. So for example, we all know that among diabetic patients, those who are using insulin typically would be older, they would have a longer duration of diabetes, and all those may confound future cancer development. But suffice to say, metformin is definitely safe to use in patients with compensated liver disease, and at least in observational studies, they appear to save life. So another drug that I would excuse me. So another drug that I would like to highlight would be statin, which is commonly used in patients with NAFLD and also in patients with diabetes. So in this observational territory-wide study from our group, we showed that people who were using statin actually had a lower risk of developing HCC. But I also have to highlight that the data come from patients with chronic hepatitis B. Whether or not the same applies to patients with NAFLD deserve further evaluation. But suffice to say, many NAFLD patients would have dyslipidemia and diabetes, and statin is strongly indicated anyway. And many studies have also shown that statins are actually safe in patients with compensated liver disease. And the risk of ALT elevation is actually not increased when you prescribe statins, so prescribe more. So in conclusion, Chairman, ladies and gentlemen, what do we know about NASH-related HCC and what can we do about it now? So we know that more than 20 to 30% of NASH-related HCC may arise from non-cirrhotic patients. And therefore, it is important to identify risk factors and develop prediction scores. So at the moment, what I would do is still for older patients or for people with diabetes, they represent a high-risk group and they deserve further evaluation and monitoring. We also know that the tumor markers that we have been using, such as alpha-fetoprotein, does not work well in people with NASH-related HCC. So for high-risk groups, ultrasound definitely should be considered as a surveillance tool, and it is also our job as investigators to develop new HCC biomarkers. We know that lifestyle intervention can cure NAFLD and NASH and may even prevent HCC. So this is beyond doubt, and this should be advocated in all NAFLD patients. The more important question is how to implement that in our clinical practice. And we know that the doctor's advice is close to useless, so a multidisciplinary approach and liaison with dietitians and other healthcare providers would be very important. And finally, pharmacological treatment for NASH is at its infancy. So at the moment, we can prescribe metformin and statin more to our patients in need. And at the same moment, we also need to contribute to the drug development in patients with NASH. So apart from participating in multi-center trials, we can also contribute by validating surrogate endpoints to facilitate drug development. It does not make sense to require multiple liver biopsies in the same patient. This would just slow down the entire drug development process, so good surrogate endpoints, good biomarkers would be very important. And we also need some proof of concept studies to show that some of the new agents actually can prevent HCC. And this concludes my talk, and I would end by thanking everybody and also sharing with you a picture from our university. Thank you very much.
Thank you, Professor Wong, for an excellent talk. So I think we have time for just one question. Any question? Please, Professor Reddy.
Thank you, Professor Reddy.
It's a nice overview. You know, at least in the U.S., we see a different phenotype. We're seeing a lot of hepatic adenomas in patients with NAFLD, metabolic syndrome. Can you speculate on the mechanism for seeing hepatic adenomas? Is it the same path, and also could it be that these patients have hepatic adenomas that de-differentiate into cancer rather than de novo cancer?
Okay, so I think those questions, we do not have complete answers, but I can speculate. So what we know is that among patients with NASH, there is a heightened response with a lot of hepatocyte apoptosis, which is beyond what we observe in other liver diseases. So if we consider why some patients would develop hepatic adenomas and also carcinomas, so one important concept is the clonal expansion. So when you have more cell deaths due to apoptosis, this would lead to liver regeneration. And we know that in this process, there would be some clonal expansion of some of the hepatocytes, and this may promote the development of adenoma. But certainly, the clinical impact deserves a further study, and we just need more data.
Thank you. So thank you to all speakers, and I think we'd like to end up this session to move to the next symposium session. Thank you.